Thank you for joining us for our webinar, Epilepsy and Suicide. Today's presenters are Dr. Andy Canner, Professor of Clinical Neurology, the Director of Comprehensive Epilepsy Center and Head Section of Epilepsy at the Department of Neurology, University of Miami, Miller School of Medicine. And also joining us are Dr. Bart Andrews, Chief Clinical Officer for Behavioral Health Response.
So good evening, ladies and gentlemen. It is a great pleasure for me to participate in this webinar on a very important problem that all of us neurologists and epileptologists deal on a daily basis when we manage patients with epilepsy, and that is the problem of suicide in our patients. And the question is, what can we do about it? What I am how frequent this problem is, what are the factors that increase the likelihood that people with epilepsy will develop suicidal ideation and behavior, you're going to understand the complexity of the problem, the role that occasionally medications that we use to treat seizures can play in the development of suicidal ideation, and what can we as physicians do to identify patients at risk for suicidal ideation and behavior. What are the various clinical manifestations of suicidality? First, you can experience passive suicidal ideation, which is the less severe forms of suicidality, where the individual has the idea, I'd be better off dead, but I am not thinking of anything to hurt myself. But if this worsens in severity, it can lead to active suicidal ideation, at which point the person starts thinking, what can I do to commit suicide, and starts elaborating plans to carry out this ideation. And that can lead then to active suicidal ideation with a plan, at which point things become much more risky for the patient. And this then leads to a suicidal attempt that, if successful, can result in a completed suicide. The suicidal symptoms may be the expression of a variety of factors. One is the presence of psychiatric disorders that we call interictal, that is, those are psychiatric disorders that occur independently of the occurrence of seizures. And those are the most frequent type of psychiatric disorders that are associated with the development of suicidal ideation. But they can also occur when the individual has seizures, and then after that seizure, like a day or two or within 5 days, the person starts experiencing suicidal ideation, and that suicidal ideation often can evolve into suicidal behavior. This is what we call postictal episodes. And finally, they can be the expression of iatrogenic episodes. Iatrogenic means they are triggered by a side effect of the anti-seizure medication or anti-epileptic drugs, but can also be a consequence of epilepsy surgery that is performed in people with epilepsy that does not respond to medication and is treated with a surgical procedure. Occasionally, these patients may start experiencing suicidal ideation and can have suicide attempts. How frequent is suicide in people with epilepsy? In the general population, and this is data from epidemiologic studies done between the years 2014 and 2015, the death by suicide was estimated at 0.6%. In people with epilepsy, and this is a list of studies that investigated deaths by suicide, the mean prevalence of suicide of death by suicide in people with epilepsy was 11.5%. In general, it is estimated that people with epilepsy have a threefold higher risk of committing suicide than the general population. In the course of the life of a person with epilepsy, it is seen that 1 out of every 4 people with epilepsy will experience at some point suicidal ideation, compared to 13% of people in the general population. So as you can see, it's twice the lifetime prevalence of suicidal ideation is twofold higher than that seen in the general population. And this is data from a population-based study. So thus it represents what happens in the average person with epilepsy. Suicidality can be identified at the time that the diagnosis of epilepsy is made. This is data from a study that was recently completed in 28 epilepsy centers in the United States and Europe and Australia of 347 people who suffered from focal epilepsy. At the time of diagnosis of epilepsy, 10% had already been experiencing suicide, and 20 in the previous 6 months, and 23% endorsed suicidal ideation at some point in their life. So what this data shows is that suicidal ideation in people with epilepsy is not a consequence of a long-standing seizure disorder, but it can be identified early in the course of the diagnosis of epilepsy. And in fact, studies from Denmark have identified an increased risk of completed suicide within the first 6 months after the diagnosis of epilepsy. In this study of 347 patients, 5% had already attempted to commit suicide, and 4 of the 17 subjects had attempted suicide within the previous 2 years. This is another study that shows the prevalence of suicidal ideation in people with chronic epilepsy that has failed to respond to medical treatment. And as you can see, the prevalence of suicidal ideation is 18.5%, and the prevalence of suicidal attempts is 4.9%, which is quite similar to the prevalence of suicidal ideation and behavior seen in people with newly diagnosed epilepsy. Post-ictal suicidal ideation, that is suicidal ideation that follows the occurrence of seizures, and this can occur within a day to 5 days after a seizure, is frequent in people whose epilepsy is not well controlled with medication. This is a study of 100 consecutive people with epilepsy that has not responded to medication. 13 of these 100 people endorsed having suicidal ideation after more than 50% of their seizures. And the median duration of the suicidal ideation is 24 hours, with a range that goes from 1 hour to 240 hours. So as you can see, suicidal ideation and suicide attempts can be seen at every stage of the disease. Suicidality in epilepsy is a multifactorial and complex problem. It can be associated with mood and anxiety and psychotic disorders, with personality disorders, as we showed before, associated in post-TikTok psychiatric episodes, that is, those that follow the occurrence of seizures. It can be seen in people with a family psychiatric history, and particularly where there is family history of suicidality. It has been associated with certain anti-epileptic drugs, and we'll talk about that in a few minutes. It can be seen more frequently with certain type of seizure disorders, particularly those that involve the temporal lobe structures. But there is in the presence of psychosocial problems, but there is a interrelationship between all of these variables that feed into each other and eventually facilitate this development of the suicidal ideation and eventually suicidal attempts. There is a bidirectional relationship between suicidality and epilepsy. What does that mean? What that means is that people with epilepsy have an increased risk of developing suicidal ideation and behavior and attempting and committing suicide, but people who have had suicidal ideation and behavior also have an increased risk of developing epilepsy. And this is data that has been derived from population-based studies. In this study done in the United Kingdom, for example, 0.8 to 5.4% of people who suffered from suicidality, psychosis, and bipolar disorders went on to develop epilepsy, compared to 0.1 to 2.4% of people without epilepsy. That is, people with the psychiatric disorders and suicidality were more likely to develop epilepsy than people without the psychiatric disorders. And here in this graph, you can see in the vertical line is the onset of the epilepsy. And you can see then in the 3 years prior to the onset of epilepsy, people who had suicidality were fourfold more likely to develop epilepsy than the control group. And during the 3 years after the onset of epilepsy, the people with suicidality, with epilepsy were fourfold, and then it went down to twofold more likely to develop suicidality. So these graphs nicely represents the bidirectional relationship between the two conditions. How can we explain that psychiatric phenomena like suicidality may increase the risk of the development of a neurologic condition like epilepsy? The answer is that both conditions and the psychiatric disorders that are associated with suicidality share common pathogenic mechanisms that exist on both conditions. Now, this is data from a population-based study done in Denmark that clearly shows that people with epilepsy that do not have any comorbid psychiatric disorders have a 2.4 higher risk of developing a completed suicide. So this data pertains to completed suicide. In the presence of a mood disorder, that risk increases 32-fold. In the presence of an anxiety disorder, the risk increases 11.4-fold. And in the presence of a schizophrenic disorder, it increases by 12.5-fold. So psychiatric comorbidities clearly are an increased risk for the an increased risk of completed suicide. And this is compared to the general population. This is another study shows the data from people with newly diagnosed epilepsy, particularly epilepsy of focal origin. And here we investigated what type of mood and anxiety disorders were predictive of lifetime suicidal ideation and suicide attempts. And as you can see, the major anxiety disorders, such as panic disorder, agoraphobia, were predictors of this type of suicidality, whereas bipolar disorder and major depression were predictors of suicidal ideation and suicide attempts. Now, in 2008, the Food and Drug Administration came out with a warning indicating that anti-epileptic drugs were associated with an increased risk of suicidal ideation and suicidal behavior. They derived these conclusions from looking at data from studies that were submitted to the FDA by the pharmaceutical companies that manufacture the different anti-seizure medications, and in which the anti-seizure medication, the trials consisted of giving patients either the active drug or a placebo. And the FDA looked at the prevalence of suicidal ideation and behavior between people randomized to the active drug or the placebo. And they concluded that the people who were randomized to the active drug reported frequently suicidal ideation and suicidal attempts. However, when the American Epilepsy Society, which is a professional epilepsy society in the United States, looked at the methods used by the Food and Drug Administration in their data, they found a lot of methodological problems and questioned the validity of these conclusions. In reality, what is the accepted association between the risk that anti-seizures or anti-epileptic drugs have in increasing the risk of suicidal ideation and behavior is that there are some anti-seizure medications that can increase that risk, but not all anti-seizure medication. And in addition, that increased risk occurs in people who have a prior psychiatric history of mood or anxiety disorders or other psychiatric disorders. And among the drugs that can cause an increased risk of psychiatric disorders which can then lead to the development of suicidal ideation and behavior are the barbiturates, such as phenobarbital, the benzodiazepines, levetiracetam, topiramate, zonisamide, vigabatrin, diagabine, perampanel. Now, there are certain anti-seizure medications that, in fact, have mood stabilizing properties and that is used to treat mood and anxiety disorders. And in patients who are taking this medication and who had a previous psychiatric history of a mood or anxiety disorder, and in whom these medications resulted in the remission of their psychiatric symptoms, the discontinuation of those medications can bring up to the surface those psychiatric symptoms. These include carbamazepine, valproic acid, oxcarbazepine, lamotrigine, and among the drugs that have anti-anxiety effects are gabapentin, pregabalin, and the benzodiazepine. But the message I want to leave you with is that the risk of anti-seizure medications causing suicidal ideation and behavior is small. Number two, it occurs in people who have a previous psychiatric history or a family psychiatric history. And this history has to be always investigated at the time that the patients are being evaluated for their seizure disorder. And in patients where there is a previous psychiatric history, the use of these medications have to be prescribed with caution. However, the information that appears in the package insert of all anti-seizure medications that these drugs can cause suicidal ideation and behavior is not accepted today by the professional societies. Now, what are the most important predictor of suicide attempt in somebody who is experiencing suicidal ideation is a history of a prior suicide attempt. So a patient who's been experiencing passive suicide ideation or active suicide ideation who had a previous suicide attempt has to be evaluated very carefully because those are the patients who are at an increased risk of committing suicide. And what can we do to prevent the suicidality? In the clinic, we use screening instruments. These are short instruments that are given to patients that identify the presence of symptoms of suicidality. One of these screening instruments is the mini international neuropsychiatric instrument, the suicidality module, that investigates if the patient has ever made a suicide attempt and the symptoms for the previous month, where if there is a history of suicidal ideation, of passive suicide ideation, or active suicide ideation with a plan, and if the patient has actually in the previous 4 weeks attempted suicide. And these screening instruments can generate a severity risk that can be extremely useful for the clinician to establish how seriously this patient suicide risk is and what is the urgency to intervene. Another easy way of identifying in the office if a person is having suicidal ideation is by giving patients the item 9 of the Beck Depression Inventory, which is a questionnaire that investigates the presence of symptoms in the previous 2 weeks, the presence of symptoms of passive suicide ideation or active suicide ideation. And then finally, there is the Columbia Suicide Severity Rating Scale that is a much more complicated instrument to use in the office because it's longer. It has to be administered by trained personnel, but it's used today in every drug trial that is done in people with epilepsy who are being tested for anti-seizure medications. And it gives a lot of information as to the lifetime history of suicidal ideation, suicide attempts, and recent suicidal ideation. What I do in trying to understand a patient who reports having suicidal ideation is I ask him, what keeps you from trying to end your life? Because that gives me a very concrete idea of where is his or her thinking. If a patient tells me, well, I've been having these thoughts for a long time, but I would never do it because, you know, of my religion and I have family, it gives me a sense that we need to obviously treat this patient, but it's not somebody who needs to be seen in the emergency room. In contrast, if the patient says to me, the only reason that I haven't done anything is because I haven't been able to find the proper instrument to kill myself, that patient would need to be seen immediately in the emergency room by a psychiatrist. Every person with epilepsy needs to be screened for depressive episodes and anxiety disorders and suicidality in the office. And for screening for major depressive episodes, we use the NDDIE, which is a very easy instrument that has 6 items. It investigates the presence of these symptoms in the previous 2 weeks. And if people score above 15, it is suggestive of a major depressive episode. For anxiety disorders, there is a generalized anxiety disorder 7, which has 7 items, and also investigates the symptoms of the previous 2 weeks. And in people who score above the score of 10, that would suggest the presence of a generalized anxiety disorder or panic disorder. As you remember from the data I showed you, mood and anxiety disorder are very frequent psychiatric conditions associated with suicidal risk. So in conclusion, suicidality is relatively frequent in patients with epilepsy and can be identified at the time of diagnosis of epilepsy in a significant percentage of patients. Its causes are multifactorial but are easily identifiable. Screening for depression, anxiety, and suicidality can be easily carried out in the outpatient neurology and epilepsy clinics, and early recognition of suicidal risk can minimize the development of suicidal attempts. And with that, I will stop, and I want to thank you for your attention.
Well, we just saw Dr. Canner do a wonderful presentation about suicide and the intersection of suicidality and epilepsy, and that was fantastic. I'm going to talk more about, hey, when we do become aware that someone isn't doing well, when we do become aware that someone is having a suicide crisis, what do we do about it? And what are some of the challenges around that, right? And so when we talk about suicide awareness save lives, it really does. In fact, anybody, you don't have to be a clinician, you don't have to be a psychiatrist, you don't have to be a psychologist like me to help people at risk of suicide. Anybody can play a positive role in keeping people safe from suicide. There are some barriers in the way, and we're going to talk about some of those barriers really quick. We have a real problem with language. Our language around people with behavioral conditions like suicidality is incredibly biased. Unlike cancer or heart disease or diabetes, we tend to blame people for substance use disorders. We blame them when they're depressed. We blame them for suicide. So a lot of our language reflects a lot of our views that are old-fashioned, out of date, and really quite discriminatory. For instance, the term commit suicide. Why do we use that term? Well, most of the United States law is based on English common law. If you didn't know that, look it up. It's true. And in English common law, suicide was a crime against the crown and also a sin against God. People used to actually lose their property if they killed themselves. The family was kicked out of the home if it was determined it was suicide. And that eventually changed, but the language hasn't changed. So when we say someone is thinking about committing suicide or they're going to commit suicide, we're telling the person with thoughts of suicide that what we think about them and what we think about suicide. It's a sin, it's evil, it's a crime, right? Think of the other words we put commit in front of: rape, murder, fraud, sin, crime, right? So we really need to focus on language that reflects a better understanding of suicide. So people attempt suicide or they die by suicide. We don't want to talk about a successful suicide. Oh my God, have you ever heard anybody say, oh, did you hear about Jill? She had a successful cancer. Yep, she's dead. Yeah, that cancer was super successful, wasn't it? Or did you hear about Bob? He had a failed heart attack. Didn't even die from it. It was a failed heart attack. Can you believe it? I don't even like completed, to be quite honest with you. They didn't run a marathon or graduate from high school. They're dead, right? People have died from suicide or suicided. We talk about people being non-compliant. Oh my God, I hate that word, right? Now look, now those of you who take epilepsy medications, you know about the side effects and how hard it is to stay on that medication. It's not easy. Antipsychotics are incredibly, incredibly uncomfortable. If you notice that nobody's selling antipsychotic medications on the black market. Why? Because nobody wants them. They're horrible, right? So we tend to have language and an approach that's very blamey. We talk about people being personality disordered. One of the worst terms we ever came up with. It's not even psychologically accurate, but we're stuck with it apparently. It'd be like telling somebody that your whole body's cancer. No, it's not that you have cancer. You're our cancer. right? We call people resistant when they're strong-willed, when they push back against our treatment recommendations, when we typically view that sort of thing as a strength. And we refer to people who are struggling with suicide or struggling with depression or emotional dysregulation as manipulative or gamey. These are horrible, unhelpful terms to use to describe people. No wonder people are afraid to come out and tell us what they're thinking and feeling, because we often shame and judge them when they're having an emotional crisis. So this is a real problem. So we've got to be watchful of our language, and we've got to be aware that there's a lot of barriers that prevent people from reaching out and getting help when they need help, right? So a friend of mine, Desiree Elstage, talks about a diagnosis as just a label a stranger gave me. Oh my God. Look, I got really bad news. First of all, mental illness isn't categorical, it's dimensional. The psychologist lost this battle a long time ago, and we didn't lose it over research. We lost the battle because funding is driven by diagnoses. In fact, if you get behavioral health treatment, you're going to be given a diagnosis. Why? Not necessarily because you meet criteria, because the clinician is not going to be paid if they don't give you a diagnosis, right? I take amitriptyline for early morning insomnia. It's the only thing that's ever worked. I have an anxiety diagnosis, so the person can give me amitriptyline. Why? So he can get funded for the service he's providing. So we have a lot of reverse diagnoses. I'm going to give you this diagnosis so I get paid for the service and give you this medication, regardless of whether you meet criteria or not. I promise you, any good psychologist, therapist, psychiatrist can diagnose you with something if you come into their office and you're having some sort of distress. Promise you, you'll meet criteria for something, because we're not going to get paid otherwise. Which leads me to, we have this really bizarre notion that emotional struggling, substance use, suicide are something about the person, inside the person, that's coming out and impacting the world around them. In fact, we even ask, oh my God, what about all the social problems that substance use causes? Or what about the social problems depression or suicide causes? It's the opposite. It's how social problems cause substance use, cause depression, cause suicide, right? It's externally driven. Culture is a much larger driver of suicide behavior. I'll give you a good example. Suicide rates at a global level, some countries have 40 to 50 suicides per 100,000. Some countries only have 3 suicides per 100,000. You can't explain that with genetics. You can't explain it with internal biological dispositional traits. It's culture, culture, culture. So we have to create, to stop suicide, to help people, we've got to change the culture. We've got to change the way we behave around people who are struggling, right? So first, we're going to talk about, what do you do if you're struggling, right? What are things that we need to do? It's natural to have escapist thoughts. In fact, at the root of suicide is not a desire to death. Dr. Joyner, who's one of my heroes in suicide prevention and suicide research, talks about how at the root, it's a desire to get away from pain when we feel trapped and helpless. I just wish I could get away from this. I just wish this would go away. Over time, if things don't get better, sometimes those thoughts of escapism lead to thoughts of killing yourself, right? The good news, and Dr. Kenner points this out, very, very, very few people who have suicide thoughts actually go on to even attempt suicide, let alone kill themselves. Although the rate among folks with epilepsy, their rate of suicide thoughts to attempt behavior was actually pretty high, right? Which was really intriguing. By and large, the overwhelming majority of people who have suicide thoughts will not go on to kill themselves. They won't even most likely attempt. So we need to normalize suicide thoughts while we absolutely do not normalize suicide behavior. In fact, I'm going to tell you something that may surprise you. We need to ramp up the stigma around suicide behavior. Cultures that have strong cultural taboos against suicide behavior, guess what? They have much lower rates of suicide. So shocking, isn't it? Normalize suicide thoughts. Do not normalize suicide behavior. Normalize help seeking, right? When someone is struggling with suicide thoughts, it's a sign that some need is not being met. More and more suicidologists are taking a needs-based approach, not a risk-based approach, which is pretty much looses. And in fact, by and large, risk stratification, unless done under circumstances that most people are not capable of doing or using the instrument. There's only 1 or 2 instruments that do really good risk stratification, is not a particularly helpful idea. Instead, we want to focus on identifying needs and then treating those needs. By and large, cardiologists are not trying to predict when you're going to have a heart attack. They're identifying the medical causes that are contributing to your cardiac problems, and let's treat those medical problems. That's really the approach that we're moving towards in suicidology. We're moving away from risk stratification or trying to predict, because we're really, really bad bad at it. In fact, clinicians are worse at predicting suicide than chance. Not great, right? Being proactive saves lives. It's incredibly, incredibly helpful to be proactive. You're not alone. There's over 40,000 suicide deaths per year. A friend of mine, Dr. Julie Searles' research found that each death impacts over 100 people. So we know over 4 million people become lost survivors every year. Let's take that math even further. There's over 1 million suicide attempts every year. That means over 100 million people are connected directly or indirectly to a suicide attempt survivor. I promise you right now, you have someone in your social network who's a suicide attempt survivor and you have no idea they've ever attempted suicide because we don't talk about it. I'm a suicide attempt survivor. It took me 16 years to talk about it. Up to 5% of Americans experience suicide thoughts during any year. That's over 15 million a year. During COVID, there was some survey research that suggested that suicide thought prevalence reached 50%. Guess what? The suicide rate went down during COVID. By and large, at a national level, in fact, at a global level, suicide went down. But Bart, if suicide thoughts went up, how could suicide deaths go down? Because there's a big gap between suicide thoughts and actual suicide behavior. That's where we intervene. That's where we can help, right? Helping requires some understanding. First of all, I'm gonna blow your mind. Suicide is not caused by mental illness. This idea that suicide is caused by mental illness is based on what are called psychological autopsies. I can spend hours telling you why it's a flawed method of identifying mental illness as a cause of suicide, right? It's not caused by bullying. In fact, bullies are just as high at risk of suicide as people who are being bullied, and people who are bullying and bullied at the same time are at even higher risk. Not surprising, because people who are in distress, people who are in emotional pain are more likely to be bullied and to bully. Suicide is not caused by media, music, or video games. Despite all the nonsense about media contagion, people don't see a news story about Robin Williams killing himself and then kill themselves. It's much, much more complicated than that. In fact, a study just got released today that having people with suicide thoughts read other people's journals and thoughts about suicide who are struggling with a suicide crisis reduced their suicide ideation. Go figure. I predicted that, by the way. Suicide is not caused by talking about suicide. In fact, talking openly and honestly in a caring way about suicide is the best way that we have to reduce suicide risk. One of my favorite studies looked at two different cultures inside the Netherlands. Two groups that live side by side in the same region of the Netherlands, I believe southwest part of the country, where there is an indigenous German-speaking group and an indigenous French-speaking group. And the suicide rates between the groups are very different, one being about 3 or 4 times higher than the other group. So they try to figure out, why are the suicide rates different? These people live in the same place, they have the same kind of jobs, they have the same socioeconomic status. The biggest difference was the French speakers freely talked about their depression, their thoughts of suicide. They had no qualms about expressing their negative emotional states and reaching out to others when they were struggling. The German speakers did not do that. Silence kills. Suicide behavior is complicated, and understanding things that drive it really, really helps. We need to get away from what's wrong with you. This is an old medical model that when you are struggling emotionally, there's something inside that's wrong with you that we fix. That's not really accurate by and large. There are some exceptions to that, but I'm not going to bore you with the details. We need to start adopting an injury-based model, which medicine actually has really good. Notice when somebody falls and breaks their leg, we don't call them a broken leg person. We realize they had an injury and the pain and the damage to them was a result of an injury, not something about them specifically. We don't do that behavioral health. We assume there's something wrong with that person. It's really bad. It's really not helpful. It's also not accurate. So adopt an injury model. What happened to you? What's going on that's got you feeling this way as opposed to what's wrong with you? It changes lives. Suicide thoughts are highly treatable. In fact, the research shows, look, the old model we know doesn't work. The idea that if someone's depressed or anxious and suicidal, we treat their depression and we treat their anxiety, that reduces suicidality. Not true. That's not what the data shows us. The only treatments that we know that effectively mitigate suicide behavior are treatments that directly address the suicidality. There are some exceptions to that. Chlorpromazine and lithium both are medications that have some strong anti-suicide preventive methods where you're not directly, ketamine, we're having good luck with ketamine as well. But most talk therapies, if you don't directly address the suicidality, you're not going to have a successful outcome. Suicide thoughts are highly treatable. If we get people to talk about them, we can intervene, and that's really powerful, right? Some quick steps. What is different? What's going on? What's new? If someone is struggling, if you're struggling, start looking around and identifying what are the stressors, what's possibly causing this? Do you already know? Understanding our own story helps us gain perspective. Who can you talk to? If you can talk to somebody, do it. The worst thing someone can do if they're struggling and if they're in emotional pain is not talk to someone. In fact, there's a lot of indication that the reason we have negative emotional states is to actually prompt us to engage in social behavior, to reach out and connect with other people, right? That's one of the main purposes of anxiety is social cohesion. We get anxious when we're alone. Better be around people. It was life preserving, particularly back in the day when you didn't know if you were going to get attacked by a saber-toothed tiger when you're out on your own, right? Peer support and is really important. Having a good social network you can lean on. And if you don't have one, you've got to get one. Medical and physical consults. One of the things, it was so fascinating hearing Dr. Cannon talk about that people who are having suicide thoughts are more likely to develop epilepsy. People with epilepsy are more likely to develop suicide thoughts. Medical conditions play an important role, and the mind-body connection is very real, so it's really important that we get checked out medically. Therapy works, particularly therapy that's targeted directly towards the suicide problem. There's crisis resources. We now have a national network of evidence-based suicide prevention centers that you can reach by dialing 3 digits, 988. You can get help 24 hours a day, 7 days a week by very well-trained, caring, competent clinicians. Know that number, get that number out there. Very helpful. Self-care is hard work. Of all the things, oh my God, we've done such a bad job in self-care. I've been to self-care workshops where people were coloring and coloring books. Look, everybody, that's self-care. No, that's just nonsense. I'm sorry. If you like coloring, that's great. Self-care is more like physical therapy. Self-care isn't laying in a bath with bubbles and warm water. That can be nice sometimes. Self-care is things that you do every day to take care of yourself. I have got to work out every day. I'm a person in recovery. I quit drinking 24 years ago. I got to work out every day. I know there's certain things that I need to eat at specific times of the day, or I get hungry and I get a little cranky, and that leads to problems. Self-care means doing the things that you know your body needs and your mind needs, even when you don't want to do them, right? This idea that self-care is laying in bed all weekend and streaming videos, I'm going to tell you what, that's a quick way to depression, feeling helpless and miserable. Self-care means doing things to take care of yourself, active. Sometimes you got to start small, baby steps. Behavioral activation is really important. Often our response to anxiety and depression and we're feeling low is to shut down and do less. And it's really bad because actually we need to do more, right? Small steps. If we're really struggling, we want to set ourselves up for success. Take small steps, things that we can accomplish, things we can feel good about. Set yourself up for success, not failure. And communication is absolutely key. Family and friends are never the cause of someone's suicide, although when we lose people to suicide, we often feel to blame. It's not our fault. You can try to take responsibility if you want, but it's not your fault. People have self-agency. They make choices, and suicide is a choice by and large. There's very few exceptions to that. We cannot be responsible for someone 24/7. It's absolutely impossible. Hell, what they don't want to tell you, about 1,500 people a year kill themselves on psychiatric units. If a psychiatric unit can't stop someone from killing themselves, how in the heck is a family member or a friend going to physically prevent, monitor, and prevent someone from killing themselves? You can't do it. But there are things we can do that make it more likely the person will stay alive, stay connected, and not kill themselves, right? Without taking ownership. Our primary goals are in helping is to increase belonging. I call that acceptance. Reduce burdensomeness, increase value, means restriction, make their environment safer, provider support, get them connected to good, competent clinicians that can address their medical needs, their mental health needs, and their suicide crisis. These are things that save lives. Acceptance equals talk. Talk openly and honestly about suicide. If you're worried about somebody, if somebody is saying a lot of things that are fatalistic, some of the examples and then some of the screening tools that Dr. Canner showed, I just can't take it anymore. I want to go to sleep and not wake up. I just want this all to go away. You really, at that point, should say, it sounds like things are really bad. Are you thinking about suicide? That's exactly how you ask. Don't ask any other way. Well, you're not thinking about suicide, right? That is not going to get you an honest response. In fact, they did research on psychiatrists in Great Britain, and they found that psychiatrists that had questions like, well, I'm just double checking because it doesn't look like suicide's an issue, but are you having suicide thoughts? Of course, the person says no because the doctor has told them they don't want to hear yes, right? We need to make it okay to say yes. Ask about suicide. Thoughts about dying, going to sleep, not waking up, just wanting to end or be over are aspects of suicide thinking and an indication that the person's current coping strategies are not meeting their needs and they're in trouble and we need to reach out. It's important to know the why. And it's important not to minimize the why. Really, do not say, oh, things will be so much better. You'll get through this. You don't know that. Things are bad. Sounds like things are real bad. They're so bad you're thinking about suicide. Actually validating why they're struggling creates relief and hope more than trying to build false hope. We want it to be easy to talk about. The way to make suicide easy to talk about is to let people tell you what's really going on without judging them, minimizing them, or ignoring the pain that they're in. I give do's because there's good research that shows giving don'ts as examples increase the likelihood people will do the don'ts instead of the do's. Do listen, 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 acknowledge pain and reasons for suicide. Ask them what keeps them going, what keeps them safe from suicide. Let them know you care. Let them know you have hope, even if they don't. Look, ask what you can do to help. Self-disclosure that I know you're feeling hopeless, but I've got hope for you is very different from telling them they'll get through it, right? You're owning your feelings in the matter. That, again, creates connection and trust. Here's examples of things that you can say. I'm so glad that you told me you're thinking about suicide. There is nothing more intimate between two people than for one person to disclose to another that they're feeling so bad they're thinking about killing themselves. Honor that. If someone actually tells you that, honor that. Thank them for telling you. It's a scary thing to tell. It's a scary thing to ask. It's an even scarier thing to tell. Because people are afraid you're going to lock them up in the hospital against their will. And we do that all the time, even though it doesn't really work, by the way. Highest risk period for people with suicide, post-hospital discharge. The rates are through the roof, especially if they were admitted for suicide. Go figure. I'm sad you're hurting like this. Again, that's a good self-disclosure that you can own. I'm sad that you're hurting, right? What's going on that makes you want to die? When do you think you'll act? What ways are you thinking of? Learning more about their plan is a fine thing to do, right? Help is available. Make sure they know there's help. There's hope that you can help. What can I do to help? I care about you and I'd be so sad if you died by suicide is a fine statement to make. It's not a guilt statement. You're just owning, hey, this is not what I want for you. It would make me very sad if you died. I hope you'll keep talking to me. Build in that trust. We want to keep people talking. The secret to suicide intervention is not that you're going to solve all their problems. You can't. It doesn't work that way. Good therapy doesn't solve everybody's problems. Good suicide intervention is buying time. All we're trying to do is buy a little bit of time. The overwhelming majority of people that are dealing with suicide crisis, if they get support and we keep them alive through the tough spot, they'll go on and live the rest of their lives. In fact, 85 to 95% of the people who attempt suicide do not end up dying by suicide if they survive that suicide attempt. The life instinct is really strong if we just give it a chance. Buying time, buying time, buying time. You don't need to be a therapist to help. What we are talking about is not therapy. These skills can help when they need it. If you forget almost everything we talk about, don't forget this. Talking about suicide with someone openly and honestly saves lives. Also, hey, there's other help available. 988. Listen, if you're worried about somebody, you can call 988. We will help you. I run one of the largest 988 centers in the country. We get tons of calls from third parties. We encourage it. If you have someone in your life you're worried about, call us. We'll talk to you, get a sense of what's going on. We'll even offer to call with you and talk to the person. You don't need to do this alone. There's literally skilled professional help available 24 hours a day, 7 days a week, 3 digits, 988. Call it. It saves lives.
Thank you to Dr. Canner and Dr. Andrews for this great presentation today. Please remember, if you or someone you know are having thoughts of suicide, please call 988 to speak with someone today. You can also call the Epilepsy and Seizures 24/7 helpline at 1-800-332-1000 or in Spanish by dialing 1-866-748-8008. Thank you again for joining us.